Welcome to the Integrative Medicine Podcast. I'm Dr. Jordan Robertson. In this podcast, the best of both worlds of medicine come together, informing you of your healthcare options. This podcast is for the ultra-discerning, highly critical, and results-oriented health consumer, filtering out the good, the bad, and the real ugly when it comes to health information. As your host, my mission is to help you navigate the world of evidence-based integrative care and confidently make choices to help you live your best life. Enjoy! Welcome to another edition of the Integrative Medicine Podcast. I'm your host, Dr. Jordan Robertson. Today we're going to be talking about one of my favorite concepts in research, especially as it applies to integrative medicine, although this is a very important concept in conventional medicine as well. We're going to be looking at surrogate markers and using fertility as an example. This is a great example of where, we have difficulty in the research helping predict whether or not we're going to hit important clinical outcomes for patients. So before we get into that topic, this is just a reminder that the purpose of this podcast is purely educational. It's not intended to diagnose or treat your condition or your disease. If you feel like you have something that is standing out as a result of listening to a podcast, I highly encourage you to connect with a practitioner that is experienced in the field and that is curious about your condition and willing to help you work on it. So this idea of surrogate markers or biomarkers, and this might sound like this topic is strictly for practitioners, although I think lots of practitioners would benefit from listening to these ideas because it certainly helps narrow down how to spend time in research, in integrative care. It also is for patients. So our well-intending, well-read patient actually could really benefit from understanding the difference between a surrogate marker and hard clinical endpoints. So this idea of surrogate marker or biomarker, some articles will use those two terms interchangeably. They're basically substitute measures of the thing that we're actually interested in. And so they are observations or measurements that we can make either earlier than the actual outcome we're tracking. They may be cheaper to test. It may be less invasive for us to do these tests or measurements, but we're going to use them in research to try and predict what might happen in our diseased population. So, for example, we may test your LDL cholesterol as a surrogate marker for cardiovascular death. And it's arguable whether or not that is a good marker to predict cardiovascular death, but that's just a really well understood or a really common example of what a surrogate marker would be. Using surrogate markers in fertility is actually really interesting because fertility is really a dichotomous result. So we have a baby at the end, or we don't have a baby at the end. There's no almost baby or kind of baby, which in lots of other things that we measure, we can kind of get results or sort of have improvement, right? If we think about pain, for an example, we can have improvements in pain that are not yes or no, whereas when we're looking at things in fertility, the outcome is really yes or no, right? Yes baby, no baby. And so it's really clear, or it should be really clear for our patients, whether or not we actually hit the target. Unfortunately, not everything in medicine is quite that clear. So we use surrogate markers to try and predict outcome. And so examples in fertility may be things like sperm motility, predicting outcome or live birth rate. We may use things like hormone levels to predict whether or not women can have a baby. We may use AMH as a prediction for ovarian reserve. Those are all just substitute measures. They don't actually measure the real thing. They're trying to come as close as we can using a cheap, non-invasive thing that we could maybe measure in many, many women to make it easier to study. For example, things like luteal phase defect, the gold standard for testing for that is actually a uterine biopsy, which really isn't practical. It's quite invasive. And so we use things like progesterone readings as a surrogate marker for what we might find on uterine biopsy, which might predict luteal phase defect. So you can see the farther we get away from the actual thing that we're trying to measure, the more likely we are to have error. And so we're using these things when they're cheaper and easier to measure, if they can be measured earlier. So oftentimes in research, when we're trying to, say, measure survival, right? If we're looking at our breast cancer patients and we're trying to look at survival, well, many, many women will live 5, 10, 15, 30 years post breast cancer treatment. And so to follow these women for that long to understand the effect of the drug may not be practical, financially feasible, and it would certainly delay us using that treatment. If we said we wanted to wait and see what happened 30 years from now to this cohort of women, it may prevent many, many other women from accessing that treatment option. And so we would use a surrogate marker like disease-free progression or perhaps tumor markers to try and earlier predict whether or not women were going to succeed on the treatment. Sometimes it's just straight up unethical for us to study the actual outcome. So Tylenol overdose and liver damage is a great example. We use liver enzymes to predict the liver damage. We wouldn't wait and use death as our outcome, right? It would be unethical for us to track death from Tylenol overdose to see how that worked. We would use the surrogate marker of liver damage instead. So there's lots of guidelines for how to decide whether a surrogate marker is good or not. And in fertility, we often get sort of caught up in surrogate markers, looking at things like ovarian reserve. We look at things like egg quality. And I think a lot of this has to do with the fact that we use so much technology in reproductive medicine that we've actually created a lot of steps and checkpoints along the way. We test sperm. We look at whether or not women respond to hyperstimulation of drugs. We look at how many follicles were retrieved. We look at how many day 3 embryos we got and how many day 5 embryos we got. And so we're actually making a lot of checkpoints along the way when we're using fertility in research. And that probably has meant that we've started to rely on these moments as predictors of whether or not women will carry to term, when truthfully they're not great markers of whether or not we actually make a baby at the end. There's even some great articles in gynecology and obstetric journals that say, technically there are no good surrogate markers in fertility care, and really a study shouldn't be considered to be good unless it actually reports the number of babies that are born at the end of the study. And so I think some of the challenges we've made, or challenges and traps we've fallen into, is to look at biological plausibility as being sort of the most important thing that we would use to determine whether or not this surrogate marker is important. So technically there's a lot of things that we should consider before using a surrogate marker as the sort of end-all be-all, or using it to determine whether or not our test or our tracking of our patient is going to be successful. But in fertility, we often use biologic plausibility as our sole way of determining whether or not we're going to use a surrogate marker. So for example, we know that there's a lot of oxidative stress or reactive oxygen species, which that's the opposite of antioxidants, right? So antioxidants squish or squash reactive oxygen species or oxidative stress. And we know that women who have difficulty with fertility have lower antioxidants in their blood. They have lower vitamin C, vitamin E. We know that they engage in a lot of behaviors that cause oxidative stress, like alcohol, caffeine, and smoking, or have obesity, which also causes oxidative stress. We know if we test the follicular fluid around the ovary of women with infertility, that they have higher levels of oxidative stress. We know that in certain conditions related to infertility, such as endometriosis, there's more oxidative stress in the uterus. We know in luteal phase defect, there is more oxidative stress around the granulosal cells that are supposed to be making progesterone. So we can see that oxidative stress is showing up in a lot of types of infertility. And so maybe there's a biological plausibility there that adding antioxidants to a woman or to the system would in theory improve whatever this problem is that is creating all of this oxidative stress. The problem is that we don't always see that. We don't always see that adding antioxidants makes more babies. Adding antioxidants reduces oxidative stress, but we haven't been able to make the link that reducing oxidative stress actually makes more babies. So when we specifically start to look at surrogate outcomes in fertility, the example that comes up that's probably the most important is looking at the concept of using CoQ10 to help support ovarian reserve or egg quality. So this was born from the findings that with advanced maternal age, we do see changes in the oxidative capacity of eggs and of the ovary itself. And so as women age, or as mice age, or any of the models that we've used to try and study older women, or what changes with women as far as reproductive capacity as they age, we find that they generally are less tolerant of oxidative stress, they have lower levels of antioxidants, and there are actual changes in their ability to make their own antioxidants. And so CoQ10 is something we can make in our own body, and so it's made from cholesterol, and in the ovary, there are enzymes that actually can produce CoQ10. And there was a couple of researchers that found that as women aged, this ability or capacity to make CoQ10 actually declined. And this was a big aha moment that perhaps this would help us understand, or this would potentially be a treatment target for advanced maternal age. So as women age, their ovarian decline is their ovarian reserve is going down, and maybe we can stop or reverse that decline if we supplemented or supported those natural aging processes, which they honed in on the lack of the ability of the cells in the ovary to make their own CoQ10, and perhaps we can improve mitochondrial health and we can improve antioxidant capacity if we supplemented back in CoQ10. So what these authors theorized was that if we supplemented the maternal diet with CoQ10, that we actually would maybe be able to reverse some of the age-related changes that were happening that they deemed were responsible for a reduction in fertility with advanced maternal age. So the question you should be asking based on sort of the topic of this podcast is, does ovarian antioxidant capacity predict live birth rate or babies? Does reversing the deficit of CoQ10 or the low CoQ10 that we see in older moms, if we reverse that, do we see more babies? There's even more questions there, right? Does giving CoQ10 orally in women, because really practically that is what we would do with patients, does that even change CoQ10 at the level of the ovary? And so some of the challenges here is that a lot of these studies initially are done in animals, and a lot of them are done in what's called in vitro, which means we've isolated the situation in a test tube in a laboratory environment, and we can study those enzymatic processes and those biological processes, but we're doing it in the absence of the rest of the human around them. And so often looking at how that we would practically turn that into a treatment is difficult, because we don't even know how well we absorb CoQ10 and whether the CoQ10 we eat would even make its way to the ovary, or if the ovary has to make its own CoQ10. But anyways, this is where sort of that idea was born, that perhaps CoQ10 could be a treatment target for advanced maternal age based on these noted changes in the ability for women to make their own CoQ10 in the ovary as they got older. And so the big remaining question is, does CoQ10 actually make any more babies? And so there actually was a great study. It was what we call retrospective chart analysis. And so the Toronto Fertility Clinic did a retrospective chart analysis of all of their patients who had used both a drug therapy, so DHEA, which is well documented for improving ovarian reserve by contrast, and CoQ10. So they compared the women who had been given DHEA alone, which is their standard treatment protocol for premature ovarian failure or low ovarian reserve, versus women who were given DHEA plus CoQ10 together. It was actually quite a large trial quite a large number of charts that they evaluated. And what they found when they went back is that technically the women who were given both the DHEA and the CoQ10 had much more follicles. They had better retrievals for their IVF. They used less medications in order to stimulate their cycle. And so technically things looked much, much better on paper for the women who had been given both DHEA and CoQ10, which perhaps would make us believe that the earlier research we had seen, right, if we get more follicles, we need less medication to help stimulate these women, maybe we are improving their ovarian reserve with the additional CoQ10. And so what they did was they tracked these charts to find out if in these cycles women actually did or didn't get pregnant with the administration of CoQ10. And interestingly, although giving CoQ10 and DHEA improved antral follicle count and seemed to improve the responsiveness of the ovary to the treatment, so that was like the drug stimulation they used for IUI or IVF, it didn't change the outcome. So whether or not women had CoQ10 added to their treatment plan, they made the same number of babies as women who didn't use CoQ10. And so that is the difference between a surrogate marker and a real marker. Surrogate marker is oxidative stress at the level of the ovary, which we can correct with CoQ10. The thing that matters to the patient or to you is the baby, and it doesn't actually change the babies. It doesn't change the number of babies born if we give women this supplement. So it certainly begs the question whether or not we actually would focus on this as a potential treatment option when there are so many other treatment options that actually do influence live birth rate. Now, since this chart analysis, there's actually been 2 other attempts at trying to figure out if CoQ10 improves fertility. One of the studies that was published and was completed, although I think they terminated the trial early, was showing no difference in live birth rate in women who were using CoQ10 or not. The problem is that this particular study was using a really invasive and high-risk procedure to try and evaluate whether or not the CoQ10 had influenced oxidative stress in the embryo. So they actually were doing something called a polar body biopsy of the embryos in order to find out if the CoQ10 had actually had a significant impact on the health of the ovary before it was put back in or transferred as part of an IVF. The problem is the procedure that they were using, that polar body biopsy, was actually terminating more of the pregnancies than the women who weren't being subject to that biopsy. And so they actually terminated the study early. But of the cases that were published, as they tracked these women over a period of years, the women who did get CoQ10 didn't have any significant improvement in live birth rate versus the women who did not receive CoQ10. It was that control group, though, that actually ended up having less problems because they weren't biopsying those embryos. They were only biopsying the other embryos, and there was a significantly higher fail rate in the CoQ10 group because those embryos had been subject to this polar body biopsy. And as a result of that, a second trial, it was called the Effective Coenzyme Q10 Together with Fertility Drugs on Pregnancy Outcome of In Vitro Fertilization. This was published on clinicaltrials.gov. This is a study that was in progress, and it was actually in the recruitment phase in Canada for women to get CoQ10 as part of their fertility care. And they actually stopped this trial even before they got started because they had actually planned to use the same polar body biopsy as the other study. And since that study had found basically it had become unethical for them to subject those IVF procedures to that biopsy to determine if the CoQ10 was even effective, that the other one didn't even get off the ground. And so as of yet, the very best evidence we have for whether or not CoQ10 works is that retrospective chart analysis. We haven't done any sort of forward tracking or randomized control trials of using CoQ10 and using live birth rate as our outcome. And so we actually don't know if it has a significant impact on live birth rate, but looking back at the women who have used it, so far we don't see any additional benefit in baby making than we do without it. But we do see some changes as far as like the number of follicles that are retrieved, etc. So hopefully that helps sort of make a bit of a statement there, because I think CoQ10 is actually part of a lot of integrative plans for fertility. I've seen it be in a lot of fertility blends from nutraceutical companies or supplement companies that are trying to encourage women to have better antioxidant health going into fertility treatment. CoQ10 will often be in those formulas, and it's important that we at least are clear with ourselves and with patients what the level of evidence actually is. There are many things that actually influence oxidative stress and cause problems with fertility. I do believe the evidence is strong enough to be convincing that oxidative stress does play a massive role in the declining of fertility, either as we age or as a result of some other underlying disease process, like I mentioned, endometriosis or PCOS or luteal phase defect. They, at their core, all have oxidative stress be part of the challenge with those women carrying to term. So absolutely do we have strong evidence that oxidative stress is having an impact on future fertility. What we don't know is whether applying that specific antioxidant is going to have an outcome. It's interesting that we spend a lot of time looking at supplementation when really there's a lot of lifestyle factors that cause significant oxidative damage. And we have looked at live birth rate with these factors, things like alcohol, cigarette smoking, caffeine, heat exposure, which is probably more specific for male infertility, as well as obesity, which has a profound impact on oxidative stress at the level of the ovary, and perhaps should be, those things, which we know actually are good markers of prediction for live birth rate. Those are the things we should be focusing on with patients, as well as some of the other antioxidants that do have significant outcomes when it comes to live birth rate. Things like perhaps NAC, things like melatonin, which will be discussed in future episodes. But we probably should be steering away from CoQ10 as a predominant antioxidant in the use of fertility. So I guess one of the last and sort of remaining important questions is whether I have used CoQ10 clinically to support my patients with fertility. What I always tell my patients that are entering the office with infertility is that everyone I see for fertility wishes they were pregnant yesterday. And so I have used CoQ10 clinically and sort of under these conditions and knowing and being very clear with patients what our options are and where it falls as far as therapeutic order. So like I said, I've already mentioned that there are other things that we should probably prioritize as far as reducing oxidative stress, things like BMI and obesity, things like melatonin and maybe improving sleep-wake quality and circadian rhythm. Those things have a profound impact, and as far as therapeutic order, we probably should always be doing those things before we would ever consider using CoQ10. However, when I was working on a short timeline with patients where perhaps I was seeing them as for the first time in the same month as their IVF procedure, if I felt like their history of oxidative stress, whether that's smoking status or obesity, whether they had perhaps used medications that lower CoQ10 in the past, then perhaps I would see a value in addition of CoQ10, since at this moment we don't appear to have any harm from CoQ10. I also have used it when CoQ10 might be continued through pregnancy for other reasons. So perhaps this is a second pregnancy and the patient's first pregnancy resulted in high blood pressure and preeclampsia, which we do have evidence for the use of CoQ10 for. Then perhaps I would consider CoQ10 as part of their treatment plan for their secondary infertility, because that may be something they would continue on into pregnancy to help reduce the risk of complications and high risk pregnancy as part of that. that pregnancy once they did achieve it. And so yes, I have used CoQ10 as part of a fertility plan, but only under those circumstances and only when it's been made clear to the patient. If they want the kitchen sink thrown at it, and we can be very clear about where an intervention falls as far as therapeutic order and what our expectations are as far as maybe antral follicle count versus live birth rate, then I think it's totally appropriate to use interventions that have not been shown to increase risk of treatment failure, that have not been shown to interact with any of their medications, and may have a biological plausibility for supporting their case. I just don't think that it should be the first thing that we gravitate towards, given that we have such a profound amount of evidence to support fertility from an integrative perspective. This concludes our episode of the Integrative Medicine Podcast. As I strive to bring you the tools and advice you need to make well-educated healthcare choices, I hope you listen along. Questions about the podcast or topic requests can be forwarded to our email at imedresearchhub@gmail.com. Remember to subscribe to receive updates on the latest episodes through iTunes, Stitcher, or Google Play.